Now we will begin today's webinar on what's legal about cancer. My name is Madison McMahon Ward, and I am the Program Manager for Triage Cancer, and it is my pleasure to introduce today's speaker, Monica Bryant. Monica Bryant is a cancer rights attorney, speaker, and author. She is the co-founder and chief operating officer for Triage Cancer. Throughout her career, Monica has provided hundreds of educational seminars, written articles, blogs, and co-authored a book published by the American Bar Association called Cancer Rights Law: An Interdisciplinary Approach. Remember, if you have any questions for Monica, please type them in the Q&A box found in your Zoom toolbar, and she will answer them towards the end of the presentation. So with that, I'd like to turn it over to Monica.
Thank you so much, Madison, for that introduction. And thank you to all of our attendees for joining tonight to learn a little bit about what is legal about cancer. People often wonder, what's a cancer rights attorney and what is actually legal about cancer? But the answer is simple, and it's almost everything. So laws can protect people from discrimination and provide health insurance access, create certain government benefits, or provide funding for screening and treatment and research. So when we talk about what's legal about cancer, we really mean almost everything. Now, certainly today, I'm going to do an overview of some of the more common topics, specifically around health insurance and employment and financial issues. But we wanted to start today's webinar with an introduction to all of the services and resources that Triage Cancer provides, because even after spending 90 minutes together tonight, you may have questions and you may want to learn more about particular topics. And so we really just want you to know where you can go to do that. When we talk about cancer care, often we use this analogy of having to put the pieces of a puzzle together in order to figure out what somebody's treatment plan is going to look like, but then also how the rest of somebody's life is going to work as well. And oftentimes it can feel like having to put together a 1,000-piece jigsaw puzzle, but never seeing the picture on the box of what that puzzle is supposed to look like. And so when we talk about the different puzzle pieces, particularly around the law, we're talking about the federal laws and programs that might be available to somebody, the state laws and programs, certainly what might be available to somebody through their employer, and what particular insurance coverage do they have with respect to health insurance and disability and other types of coverage. And then certainly the pieces around finances and medical bills certainly are going to come into play. So when we put all of these things together, that's what's going to make up somebody's puzzle. And as we get to the end of the hour, you're going to see how these different puzzle pieces can start to fit together, and that no two puzzles look the same. When people talk about the cost of care, they often talk about the financial burden or toxicity that comes with cancer care. And this term financial toxicity has certainly become more common over the last couple of years, and it was coined in 2013 by researchers out of Duke University. And in their research, they looked at how the out-of-pocket expenses and the financial burden that those out-of-pocket expenses create can be as detrimental or as burdensome as the physical toxicity that cancer care can bring. But what was particularly interesting about this research was they narrowed in on how this toxicity doesn't just happen during active treatment, but that there's also a long-term impact of the financial burden. And that long-term impact can certainly diminish overall quality of life. So while we have this new term for what we're talking about, it is certainly not a new problem. But there's no easy solution to the problem of financial toxicity, mainly because there are multiple contributing factors. And all or most of the factors have to be addressed in order to effectively mitigate or reduce financial toxicity. We believe that the primary culprit of financial toxicity is having inadequate health insurance coverage. Now, certainly that could mean not having health insurance coverage at all, but more often what we find is that people don't have the right policy for them, or they don't know how to effectively use the policy. Certainly the potential employment changes that can occur after a cancer diagnosis could impact somebody's finances. And then all of the things that normally impact our finances in life, like relationship changes or moving or graduating from school, well, those things continue to happen even after a cancer diagnosis, and they just compound the financial burden that people are already feeling. So again, we at Triage Cancer believe we really need to be addressing all of these different factors in order to be effective at minimizing or reducing the financial toxicity. So we're going to start with what I mentioned was the number one contributing factor, which is health insurance. One of the biggest challenges around health insurance for people is that very few Americans actually understand how health insurance works. And we've known that anecdotally for years, but we now have data to back it up. And this is just one of the many studies that showed us only 4% of Americans could actually define the four most basic and often used terms in health insurance. So if only 4% of Americans could even define the terms for you, how could we possibly expect Americans to be savvy consumers when it comes to picking health insurance policies? So health insurance is like learning a new language, but nobody's really teaching that language anywhere, except tonight. We're going to teach you the language. So there are three main places where Americans get their health insurance coverage. The largest number of Americans get their coverage through an employer. The second largest group gets their coverage through the government, primarily through Medicare and Medicaid. And the smallest number of Americans get their insurance straight from an insurance company. Now, regardless of where you fall in this triangle of coverage, there are some basic terms that are going to be used in all of these different policies. And we're going to start with the terms related to cost. So there is a cost that you have to pay each month just to have health insurance. And that's referred to as your monthly premium. This is going to be a fixed dollar amount, and you're going to pay it every single month, whether you go to the doctor or not. It's very similar to having homeowners insurance, but never filing a claim. Then there are some other costs that you're going to incur when you actually use your health insurance. And the first is your deductible. This is a fixed dollar amount that you're going to pay each year, and you have to pay this out of pocket before your health insurance company starts picking up their share of the cost. Their share of the cost is referred to as cost share or co-insurance, because you're literally sharing the cost. And this is a percentage. Now, you're going to pay this each time you get care once you've met your deductible. So you could have a policy that has an 80-20 cost share. That means once you've met your deductible, the insurance company starts paying 80% of your healthcare costs, and you're responsible for 20%. Many policies have an additional payment called a copayment. And this again is a fixed dollar amount that's going to depend on the policy and many times the service that we're talking about too. So for example, you could have a policy that says you have a $25 copayment every time you go to the doctor, or a $35 copayment to see a specialist, or a $250 copayment to go to the emergency room. Now, the last term related to cost that I want to talk about is referred to as your out-of-pocket maximum. And this again is a fixed dollar amount, and it is the most that you should pay out of pocket for your healthcare per year. The way you get to your out-of-pocket maximum is by adding up everything you pay out of pocket except those monthly premiums. So it's everything you pay towards a deductible, towards your co-payments, and towards your co-insurance. Now, the devil is in the detail here. Most policies will only count payments made towards in-network providers towards that out-of-pocket maximum. And some non-marketplace plans may have a slightly different formula or math problem as to how do you get to that out-of-pocket maximum. But it's very valuable to understand what your out-of-pocket maximums are, because you can then plan for a worst case scenario during the year. So let me give you an example of how this all works. Meet Dan. Dan has a policy with a $2,000 deductible. It's an 80/20 co-insurance, and it has an $8,000 out-of-pocket maximum. Dan hasn't been to the doctor all year, but it costs him $102,000 in a hospital bill. So what does Dan have to pay? Well, the first thing we always have to pay is that deductible. In Dan's case, it's $2,000. We subtract it from the overall bill, leaving $100,000 left. He has the co-insurance of 20%, which equals $20,000. Does he have to pay the $20,000? The answer is no, because he has that out-of-pocket maximum. Since he's already paid $2,000 towards his deductible, he only has to pay another $6,000 to reach his out-of-pocket maximum, and then the insurance company covers the rest of the bill at 100%. Now, I am not suggesting that $8,000 isn't a lot of money. Of course it is. But when we start looking at the alternatives of what Dan would have to pay without the out-of-pocket maximum, or what he would have to pay without health insurance at all, it starts to feel a little bit more reasonable. It's also what helps us plan for that worst case scenario. He knows that no matter how much he's going to need of medical care, the most he's ever going to pay is that out-of-pocket maximum. Now, he will have to continue paying those monthly premiums, but that's all he will pay for the rest of the year. So with those terms under our belt, I want to move into some of the consumer protections that we have around health insurance, and then focus on the places where we can receive health insurance or purchase health insurance. But before I get into that, I just want to remind you all that if you want to hear any of that again, the terms or this example, that is what is included in our animated video on health insurance basics. The Patient Protection and Affordable Care Act, otherwise known as the ACA or Obamacare, touched almost every aspect of our healthcare system. But it did some particularly valuable things for individuals with pre-existing conditions. And one of the things it did was it said that as of January 1st, 2014, insurance companies were limited in what they could look at when they were deciding what they were going to charge someone for their monthly premium. So now insurance companies can only look at 4 things. Are you buying an individual or a family plan? What's your geographic location? So this is based on zip code. How old you are. So yes, the older you get, the more you can be charged, but there is a cap on how much more you can be charged. And in most states, if you use tobacco, you can also be charged more. So this is incredibly significant for 2 reasons. One, insurance companies can no longer take gender into consideration. Prior to January 1st of 2014, women were charged more for health insurance than men were. And perhaps even more significantly, insurance companies can no longer look at somebody's health condition or pre-existing conditions to determine price. That was pretty significant. But the ACA went one step further and said that insurance companies can no longer deny selling somebody a policy or covering services based on a pre-existing condition. I have to tell you, this is game-changing for the cancer community, certainly, but really for most Americans, because most Americans have something that could be considered a pre-existing condition. So when we take these two provisions together, what this tells us is that insurance companies can no longer deny selling us a policy or charging us more based on a pre-existing condition, which is very significant. There are also some ACA protections designed to control other types of consumer benefits. So for example, the ACA eliminated what are called lifetime and annual limits on benefits. Prior to the Affordable Care Act, we would often see patients with a $75,000 annual limit or even $1 million lifetime limit, which sounds like a lot of money, but when we're talking about cancer care, it really isn't very much money. So now insurance companies are no longer allowed to impose those lifetime or annual limits on essential health benefits. The ACA also said that insurance companies can't cancel your policy when you go to use it. And young adults up to the age of 26 can stay on their parents' health insurance plan. So it provided additional access for young adults. The ACA also tried to eliminate barriers to preventative services. So we would often hear from people who had health insurance, but maybe had something like a $5,000 deductible say to us, I know I need to get my mammogram, but with my deductible, I just can't afford it right now, so I'm just going to skip it. So even people with insurance weren't accessing the preventative services like immunizations and early screenings that they could have been. The ACA addressed that by saying most health insurance policies have to cover certain preventative services for free. And so free means you can't be charged a copay, it doesn't get applied to your deductible, and there's no coinsurance. It is literally free. The ACA also recognized that there were barriers to participating in clinical trials. And one of those barriers was that many times insurance companies would see that somebody was enrolled in a clinical trial and say, well, we're not responsible for your covering your care because you're in a clinical trial. The ACA addressed that by saying insurance companies are still responsible for somebody's routine costs associated with care. They just don't have to cover the thing that's being tested in the clinical trial. So many states already had this in effect, but the ACA made it national. And I will say for Medicaid coverage, that will go into effect January 1st of next year. So stay tuned for more information on that. So we've talked about some terms and some consumer protections. Now I want to switch gears into where do we actually get our health insurance coverage from? I mentioned that the largest number of Americans get their insurance through their employer, which begs the question, what happens if somebody has to stop working or reduce their hours even due to a cancer diagnosis? COBRA is the federal law that provides eligible individuals with the opportunity to keep the exact same insurance that they had when they were employed. It's the exact same coverage. Now, in order to be eligible for COBRA, you have to work for an employer with 20 or more employees. So the benefit to COBRA is it's the exact same coverage. The challenge with COBRA is that it can be really expensive, because when you elect COBRA, you're now responsible for 100% of the monthly premium, plus sometimes a 2% administrative fee. So it can feel very expensive. It can be very expensive. The length of time that you're allowed to keep COBRA is going to depend on your qualifying event. So if your qualifying event is that you've left your job, or maybe you've gone from full-time to part-time and your employer doesn't provide benefits for part-time employees, that would trigger COBRA coverage and you would get to keep COBRA for up to 18 months. If instead your qualifying event is that you are getting a divorce and you have insurance through your spouse's job, that would be a qualifying event and you would get to keep COBRA for up to 36 months. For people who work for smaller employers and might not be eligible for the federal COBRA, many states have a state COBRA law. Now, the details definitely vary state to state, but we bring this up because if you do work for a smaller employer, you might have similar benefits under the state law. And this is the type of information that you can find on our chart of state laws under the employment section. When we're talking about COBRA, sometimes people will jump to the conclusion that based on the monthly premiums, it is incredibly expensive and it's just not worth it for them to elect COBRA. And that certainly could be true. However, there are some pros and cons to keeping COBRA. One of the benefits is that it could be better coverage. Another benefit is, since it's the exact same policy, anything you've paid towards your deductible or your out-of-pocket maximum continues. So you're not starting over from scratch. Of course, however, I've mentioned that one of the major downsides is the cost, and that monthly premium can be substantial. For people who are receiving insurance through the Medicaid program, there's a lot of confusion these days about the Medicaid program. And the reason is Medicaid isn't just one program. So prior to January 1st of 2014, in order to be eligible for Medicaid in most states, you had to have a low income level and a low resource level. Resources are things like bank accounts or retirement accounts or potentially vacation property, and be able to walk through one of these 4 doors. Most people in the cancer community were walking through the door on the left, called the Age, Blind, and Disabled program. There were some challenges with this Medicaid program, one of which was that resource requirement. So for example, if somebody had to stop working due to a cancer diagnosis and no longer had any income, but maybe they had a life insurance policy worth more than $2,000, that would kick them out of eligibility for Medicaid. Another challenge was that through the Age, Blind, and Disabled program, you had to meet the highest standard of disability that exists in the law. And so again, very, very challenging. And it was leaving people who potentially just had very low incomes without access to Medicaid coverage. The ACA tried to address this by creating a 5th door of eligibility. And this door is just based on income. So it's for people who have household incomes at or below 138% of the federal poverty level would have a new door to be able to walk through. All 4 doors that originally existed still exist with that asset test. It's just that the ACA added this 5th door that doesn't have the asset test. Now, this 5th door was supposed to be available in all 50 states. But the Supreme Court got their hands on the ACA, and in their decision, they essentially made it voluntary for states to expand. And here is where we are at the moment. Now, I will tell you that this slide changes quite frequently as elections occur at the state level, and sometimes even the local level, or voter propositions happen. We see states kind of move back and forth between this list. But right now we're at a situation where 38 states in DC have expanded and 12 states have not expanded. The states on the right represent approximately 3 to 5 million people who would have had access to Medicaid coverage had their states expanded. So Medicaid was the first federal program, health insurance program that I wanted to talk about. And the second program is Medicare. Medicare is a health insurance program run by the federal government for individuals who are over the age of 65 or people under the age of 65 but have been receiving Social Security disability insurance for 2 or more years. or for individuals who have been diagnosed with end-stage renal disease or ALS, otherwise known as Lou Gehrig's disease. Now, I will tell you, I'm going to give you a very brief overview to Medicare, but as Madison mentioned at the top of the hour, we do have a webinar coming up next month where we will spend 90 minutes going in depth into Medicare and Medicare options and how to pick plans. So if you have more questions after tonight about Medicare, please consider joining us for that webinar. Medicare is incredibly confusing, partially because it is broken up into 4 different parts. Part A is hospital insurance, and it's going to cover inpatient care, skilled nursing care, some limited home health, and hospice. If you have worked in this country and paid into the system, Medicare is likely premium free, but there may be some out-of-pocket costs depending on how long you spend inpatient. Medicare Part B is your medical insurance, which covers outpatient services. So doctor's visits, durable medical equipment, immunization, preventative services, MRIs, scans, IV chemotherapy, all of that is covered under Part B. Now, even if you have worked and paid into the system, there is still a monthly premium for Part B. For most people this year, that's $148.50 per month. There's also an annual deductible for Medicare. So remember, that's the amount that you have to pay out of pocket before the insurance starts picking up their share of the cost. Well, for Part B, the cost share is 80/20. So that means once you've paid $203 out of pocket for your deductible, Medicare starts picking up 80% of your costs, and you're responsible for 20% for the entire year, because Part B does not come with an out-of-pocket maximum. When we talk about Medicare Part A and Part B together, you may hear it referred to as original Medicare, because it's all that existed when Medicare was signed into law. Original Medicare is what's known as fee for service, which essentially means that you can go to any provider around the country that accepts Medicare and receive services, and you'd be charged the same amount regardless of where you went. So A is hospital insurance, B is medical insurance, D is prescription drug coverage. Prescription drug coverage, Part D coverage, is sold by private insurance policies, and so the cost is going to vary from policy to policy. In 2021, Part D plans cannot have a deductible more than $445 for the year. And the co-payments are going to vary based on the plan. And so really, you do have to shop around as if you were shopping for individual insurance when you're picking your Part D plan. Now, there is a ton of confusion about how Part D coverage works, and this is why. When you are thinking about your Part D coverage for prescription drugs, the very first thing that you're going to always have to pay is that deductible. So once you've paid your deductible, which can't be more than $445, you enter what's called the initial coverage phase. And at this point, Medicare pays 75% of your prescription drug costs, and you're responsible for 25%. And that continues until your total out-of-pocket drug costs reach $6,550. At that point in the year, you've entered the catastrophic coverage phase where Medicare covers 95%, and you're responsible for 5% of your drug costs or a nominal dollar fee. Typically, when we are talking about cancer care, it's going to be that 5% because that's going to be more than the $9.20. So as you can imagine, what your Medicare Part D costs are going to depend on how expensive your drugs are and where you currently are in this continuum. Okay, so part A is hospital insurance, B is medical insurance, D is prescription drug coverage. Turns out, potentially dealing with 3 different premiums, 3 different cost shares, 3 different deductibles, it's a lot. So an alternative was created in part C, otherwise known as Medicare Advantage plans. These are Medicare plans sold by private insurance companies. They have to include everything that you would get under parts A and parts B. And about 90% of Advantage plans also include prescription drug coverage. Most Advantage plans are HMOs, which means that there's a pretty limited network of providers that you get to see. Now, one of the things about Advantage plans is that you'll often hear commercials for them being sold saying, get your free Medicare Advantage plan. And it's a little bit misleading because you will at least pay your usual Part B premium for this Advantage plan. But when they're saying it's a free Advantage plan, they just mean you're not going to pay anything more than that Part B premium. And you may actually be getting more services than you would under Part B because you might be getting that Part D coverage. Sometimes they also include extra benefits like dental or vision. With Advantage plans, the deductible and the cost share is going to vary plan to plan, as will the out-of-pocket maximum. However, there is a ceiling or a cap on the out-of-pocket maximum, and this year it's $7,550. So the out-of-pocket maximum cannot be more than that. So this is generally, when we're in person, that someone will raise their hand and say, well, wait a minute, which is better, original Medicare or Medicare Advantage? And the answer is honestly, it depends. There are certainly pros and cons to both. One of the major benefits to Medicare Advantage plans is that it comes with that out-of-pocket maximum. And as you remember, Part B doesn't have an out-of-pocket maximum, so you're paying 20% all year. The downside, that smaller network of providers, and typically there isn't going to be coverage for out-of-network providers, and even if there is, it's not going to be part of that out-of-pocket maximum. So again, pros and cons, and it's really all just going to depend on what's available to somebody and then what their needs are as well. So if somebody is leaning more towards original Medicare, is there anything that they can do to protect themselves from those out-of-pocket costs, like the Part A coinsurance or the Part B 20% coinsurance? And the answer is yes. The way to protect yourself is by purchasing an additional insurance policy called a Medigap plan. Medigap plans are also called supplemental plans. I firmly believe that one of the reasons this is also confusing is that there are multiple names for exactly the same thing. And I don't know why that is, but here we are. So Medigap and supplemental are the same thing. And again, these are additional insurance policies that somebody can purchase if they have original Medicare to pick up or cover those out-of-pocket costs in Parts A and Parts B. And so basically what happens is you go and you get care, the provider is going to bill Medicare for the service, you pay your deductible, probably Part B deductible, then Medicare picks up 80%. If you've picked up a Medigap plan that covers the 20% coinsurance, like a Plan G, then that's all you have to pay. Your 20% is covered. And so for a lot of people, they kind of look at me crazy and they say, wait a minute, I'm on a fixed income and you want me to pay Part A, Part B, Part D, and this Medigap nonsense? And I recognize that it does sound sort of counterintuitive, but when you think about the out-of-pocket costs and the unknowns, purchasing these additional Medigap plans is a way to protect yourself. So in summary for Medicare for tonight, when you are trying to figure out your Medicare options, there are essentially two different lanes that you can drive in. The first lane is original Medicare, and that's where you pick up Part A for your hospital insurance, Part B for your medical insurance. If you want prescription drug coverage, you'll purchase a Part D plan sold by a private insurance company. And then if you want to fully protect yourself, you will purchase an additional insurance policy called a Medigap plan, otherwise known as a Medicare supplemental plan. So that's lane one. Lane two is Part C, otherwise known as Medicare Advantage. And these again are plans sold by private insurance companies that will bundle all of the services that you would get under Part A and Part B, and many include prescription drug coverage. If they don't include prescription drug coverage, then you can purchase a standalone Part D plan, again, sold by a private insurance company. And that's where your options end in lane two. You cannot purchase a Medigap plan in lane two. And the reason for that is because lane two comes with that Part C out-of-pocket maximum. So there isn't theoretically a need for the Medigap plan. So moving on from our government health insurance options, what about the people at the very top of the triangle who need to purchase their own insurance? The ACA, or Obamacare, created state health insurance marketplaces. And these were originally referred to as exchanges, but it turns out no one knows what an exchange is. And so they renamed them marketplaces. Turns out that didn't really help people's confusion. The easiest way to explain the marketplaces is it's like Amazon for health insurance or a shopping mall for health insurance. What you are purchasing through these marketplaces is coverage sold by private insurance companies. So it falls in the top of our triangle of coverage. It's just that the marketplace provides us some tools to shop for the insurance, very much like Amazon provides us a central location tool to purchase the things that we need. Sometimes people wonder, well, if I'm buying just from an insurance company, why wouldn't I just go straight to the insurance company? Why would I buy through the marketplace? And there's a couple of reasons. So the first is that plans sold through the marketplaces have a cap on the out-of-pocket maximum. And for this year, the out-of-pocket maximum cannot be more than $8,550 for an individual or $17,100 for a family. Some plans have a lower out-of-pocket maximum, but that again is the ceiling. There are also some financial assistance options for plans sold in the marketplaces. And I will say that right now, due to the pandemic, there is additional financial assistance. And so if you have a marketplace plan, I strongly encourage you to go back to the marketplace and update your financial information to make sure that you are getting the full amount of financial assistance that you are entitled to. So all of that is to say that we actually have more options than we ever have before for health insurance, particularly if somebody is losing their employer-sponsored coverage, maybe because they're leaving their job due to cancer treatment. So the first option is to elect COBRA or state COBRA and keep the exact same health insurance that you had when you were employed. The second option would be to purchase a totally new plan through the state health insurance marketplace in a special enrollment period. So this is a period of time after you've lost your employer-sponsored coverage where you get to purchase a totally new plan and maybe get some financial assistance to do so. Potentially, you could go on another group plan. So if you are eligible to go on your spouse's plan at work, or if you're under the age of 26, maybe you can join your parents' plan. And then finally, based on circumstances, potentially you're eligible for Medicaid or Medicare now. So again, all of this is to say we actually have more options than we ever had before. But the trick with this is that you have to pick a lane and stay in it until the next open enrollment period. Here's where this comes into play. So many times we hear from people that they were leaving their job, they were in the middle of treatment, they were sort of panicked, and they just picked COBRA. A few months in, they realized, wow, the COBRA premium is really expensive, and I could get financial assistance in the marketplace. I'd like to go get a marketplace plan now. And that's actually just not possible until the next open enrollment period. And we have open enrollment for the marketplaces and for Medicare every single year in the fall. And marketplaces and Medicare are calendar year plans, and so they start January 1st. So I do just want to mention, for someone who is losing their employer-sponsored coverage and is a little bit overwhelmed with the options, we have both an animated video and a quick guide that lays out these different options and how to make choices between your different options. Now, I've said a few times that we have more options than we ever have before as consumers for health insurance, but that sort of begs the question, well, great, we have more options. How do we go about making an educated decision between those different options? I'm going to walk you through a quick exercise, and I'm going to do it using examples from a state health insurance marketplace. But please know that the exact same analysis can be used whether you're trying to compare two marketplace plans, whether you're trying to compare between two plans an employer is providing you or offering you, whether you're trying to decide, well, wait a minute, do I take my employer plan, or maybe do I buy a marketplace plan? Or even if you're trying to compare two Medicare Advantage plans, it's the exact same analysis that I'm about to give you. So here we have three different plan options. A bronze plan with a $173 monthly premium, a $6,000 deductible, and a $6,000 out-of-pocket maximum. A silver plan with a $271 monthly premium, a $2,500 deductible, and a $5,200 out-of-pocket maximum. And then a platinum plan with an almost $400 a month premium, a $0 deductible, and an $1,150 out-of-pocket maximum. So assuming that I'm going to hit the out-of-pocket maximum, which when we're talking about cancer care is a pretty safe assumption, which plan is actually going to cost me the least at the end of the year? Can we tell just by looking at it? I certainly cannot. I have to actually do the math. And the way that you do the math to figure out the total annual cost of a plan is you take that monthly premium and you multiply it by 12, because that's how much you're going to pay during the year in premiums, and you add the out-of-pocket maximum. And when you do that for all three plans, monthly premium times 12 plus out-of-pocket maximum, we see that this plan 3 ends up being over $2,000 cheaper by the end of the year, even though it has a high monthly premium. So the point of doing this is that many people get sticker shock when they see that monthly premium and don't take into consideration what the actual out-of-pocket costs are going to be. So by doing this simple, quick math, we can figure out by the end of the year how much you're going to pay, assuming you're going to hit that out-of-pocket maximum. But that's just step one. We also have to look at some of the other pieces of information that we have. because many times the platinum plan may be the most expensive by the end of the year. But even though you might end up spending the most by the end of the year, there are some benefits to still considering it. And the most significant benefit, in my opinion, is that $0 deductible, because that means that the insurance company starts picking up 90% of your health insurance costs right away. And then even after you having to pay the 10%, you only have to pay $1,150 extra. Whereas when we compare it with the bronze plan, you have to write a $6,000 check on day one for them to pick up anything. For many of us, it is easier to pay a little bit more each month than it is to come up with a big lump $6,000 check all at once for our insurance then just to kick in. So when we talk about the costs, certainly we should be looking at the total cost, but also we want to be looking at the things like deductibles and cost shares. The other things that we have to look at are the providers that I want to see and the facilities that I want to visit part of that plan's network? So great, I have a platinum plan that's going to cover 90% right away, but if the doctors that I want to see aren't in that plan's network, it is virtually useless to me. Same with understanding the prescription drug coverage. So if I'm taking a prescription drug that plan doesn't include in their drug formulary or list, then that's not, even though it's gonna on paper, when I do the math, be less expensive, it's not gonna be helpful because I'm still having to pay for those drugs out of pocket because they're not covered by that policy. So I fully recognize that for many people, this sounds super obvious. Like, of course you look for the networks and of course you check the prescription drug coverage. But we, outside of a pandemic, travel all over the country doing this work. And we know that for many people, this is not obvious. So very, very critical to check not just the cost, but the network of doctors and the prescription drug coverage. Now, at some point, you may find that you have a claim that gets denied, even if you've done your due diligence to pick the best policy for you. The good news is that we generally have two opportunities to appeal that decision. So generally, there is an internal appeal where you're going back to the insurance company and asking them to reconsider. And then there's an external appeals process where you go to an independent entity and ask them to look at all the facts and make a decision as to whether or not the insurance company should have covered that claim. There are many things that I say in presentations that are easier said than done, and I think appeals are definitely in that category. I recognize that we are asking patients to take on an extra burden when it comes to appealing claim denials. But when we talk about financial toxicity and the burden that patients are facing, even when they have health insurance, the appeals process is an underutilized tool. And I know that because the statistics shows us that. So just one study looking at the claims denied through the marketplace show us that less of the 40 million claims that got denied in 2019, less than 0.2%, less than 0.5% of all of those denied claims were ever appealed. But we also know that when claims are appealed, somewhere between 40 and 60% of those appeals are decided in favor of the patient. So conservatively, 50% of the time, the insurance company is getting it wrong when they deny a claim. Yet only 0.5% or less than 0.5% of appeals ever get filed. So again, when we're talking about financial toxicity and the financial burden, this appeals process is critical and it's underutilized. So certainly to the healthcare professionals on with us today, encourage your patients to appeal denied claims. And for those who have been diagnosed or caregivers on, take on that extra burden if you get the denial, Triage Cancer has several resources to try to help you with that process, including quick guides and an animated video and a full webinar on the appeals process that goes into great detail. We have one of our cancer finances modules that will break down exactly how to file an appeal depending on your type of insurance. And then we also have an appeals tracking form that you can download to help you stay organized through this process. So we recognize that it's a lot of work, but we certainly have tried to create resources to make it a little bit easier for you to do so. And on that down note of the idea that you likely will have to appeal a denial, I also have some additional bad news in that picking a health insurance policy is not a one-time chore. It is actually something that we need to do every single year. Every single year, we need to be looking at what our options are for the coming year and seeing if they meet our needs. So you may have picked an insurance policy when you were healthy, and so you picked a pretty cheap HMO, but now you have a cancer diagnosis and you want to see providers that aren't included in that network. Well, this fall is the opportunity for you to pick a new policy that does include those new providers. So insurance coverage has to change as your needs change. And then certainly as your other circumstances change, like if your family's changed or if you've changed jobs, to be looking at what types of insurance best meets your needs. And then picking a policy is only half the battle. We also have to make sure that once we have the policy, we are making the most of it. And that means using in-network providers whenever possible, asking for prior authorizations. And so that's when you go to an insurance company before you receive a service and ask them if they're going to cover the service. Certainly paying attention to bills. So we know that there are tons of mistakes in medical bills. And that's where services like co-patient that Madison mentioned at the top of the hour can be incredibly helpful. Certainly now that hopefully you have a better understanding of out-of-pocket maximums, leverage those. If you've met your out-of-pocket maximum for the year, think about what other medical care you need that maybe you've been putting off. Go get that now before everything starts over at zero. That goes for if you have an individual policy or if you have a family policy. So if you've met your family out-of-pocket maximum, think about what other family members might need medical care, again, that you've been putting off. Go get that now. It could also be about timing. So there is a story of a woman who needed to have a certain number of chemotherapy treatments. She wanted to enjoy the Thanksgiving holiday, so she postponed her treatments until right after Thanksgiving. But by doing so, it meant that now she had 2 chemotherapies that were going to occur in January, which meant that now everything started over at zero January 1st. And so she's going to have to pay her copays for those. Whereas if she had gotten it in the year before, she had already met her out-of-pocket maximum and she would have paid nothing. So sometimes it's about thinking about the other care. Sometimes it's about thinking about timing. And now that you understand how it all works, hopefully that will be a little bit easier for you to do. And then certainly appealing any denials of care is incredibly valuable. So that sort of wraps up health insurance. And I want to switch gears to our next biggest contributing factor to financial toxicity, which is employment changes. There are a number of places where we can go to figure out our employment rights. There are fair employment laws that deal with discrimination and may provide other tools for working. There are federal and state fair employment laws. There are also federal and state leave laws. If somebody is working under an employment contract or is a member of a union, their union collective bargaining agreement or employment contract could also provide additional or different benefits. But when we're thinking about what our benefits are, the law is the bare minimum of what employers are required to provide. And the reality is many employers are actually much more generous than that bare minimum. So it is imperative to be looking at our employer's specific policies for our benefits as well as to the law. And some of those policies or benefits could certainly be health insurance or disability insurance, but also, do you have access to sick time or PTO? Is there a process to request medical leave? Typically, this information could be found in some sort of policy and procedures document or employee handbook. Of course, not every employer has one of these. So if you don't have access to a written document or something that's online, certainly asking an HR representative if you have one of those, or whomever at your job handles benefits or that you turn your timesheet into, should be able to provide you with some of this information. But getting into the specifics of the law, I mentioned fair employment laws, and perhaps the most well-known fair employment law is the Americans with Disabilities Act, or the ADA. Now, there are certainly eligibility requirements to get to use the ADA's protections, including working for a private employer with 15 or more employees, or a state or local government of any size. In addition to working for a large enough employer, you have to be a qualified individual, which means that you can do the job. And then you also have to have a disability under the ADA's definition. Now, I'm not going to go into great detail about this because we do have tons of information on our website and a dedicated webinar to this. But many people with cancer do in fact meet the ADA's definition of disability. And if they do meet that definition, there are actually 4 different ways to use the ADA. So the first is that you currently have a disability. So that could be that you're in the middle of cancer treatment and you're dealing with severe nausea. You could have a history of having a disability or be regarded as having a disability. And this is really about the employer's perception of you and not really about your capacity at all. Caregivers may also be protected under the ADA based on their association with a person with a disability. The really interesting thing about the way that the ADA was written is that it applies to all phases of the employment process, which means that eligible individuals are protected even in the application process through interviewing, hiring, promotions, benefits, demotions, and firing. Through the entire process, someone could be protected under the ADA. So what does the ADA actually give someone? Well, in all of these circumstances, someone currently has a disability, history of disability, they're being regarded as, or they're a caregiver, eligible employees are protected from discrimination, which means that employers can't be making employment-related decisions based on your medical condition. For people who currently have a disability or have a history of having a disability, in addition to being protected from discrimination, they are also entitled to something called a reasonable accommodation. Now, reasonable accommodations are one of the most valuable tools for somebody who is trying to work through treatment, take time off for treatment, or return to work after treatment, and yet they are wildly underutilized. So I've given you the definition of a reasonable accommodation here, which is any change in the work environment or in the way that things are customarily done that enables an individual with a disability to enjoy equal employment opportunities. I recognize that is about clear as mud. The easiest way to talk about reasonable accommodations is through examples, and they can be put into 3 main categories. The first is about physical work space. So maybe it's about moving offices closer to your parking spot or certain furniture, or maybe it's about telecommuting or working from a different location. It could be about schedule. So maybe you need to have a flexible schedule or shift your schedule. So instead of working 5 8-hour days, you're going to work 4 10-hour days so that you always have Friday off for treatments. It could also provide access to time off as a reasonable accommodation or extended leave, which I'll get back to in just a minute. And then there's sort of everything else, which it could be using technology like speak to type software if you're dealing with neuropathy in your hands. It could be about a change in policy. So if you're dealing with temperature sensitivity, but your job has a strict dress code and doesn't allow you to wear hats, you could have an accommodation to wear a hat. It could be about shifting responsibilities to another employee, or it could be about changing jobs entirely. Now, again, this is one of the most valuable tools because it is so incredibly flexible, and you might be able to get more than one accommodation. So if you're in a situation where you are potentially dealing with side effects, whether they're in the middle of active treatment or late or long-term side effects, or you're having other challenges at work, thinking about if reasonable accommodations could be useful can be really valuable. And we have tons of tools on accommodations on our website, including an animated video and an entire webinar and tons of quick guides that explains all of the details. Now, I mentioned that in order to be eligible for the ADA, you have to work for a private employer with 15 or more employees. So what happens if you work for a smaller employer? Well, you would look to see if they have a state fair employment law. And this chart shows you the number of employees an employer has to have in each state to qualify for the state fair employment law. So for example, if you're in Illinois like me, you only have to work for an employer with 1 or more employee to be covered by this Illinois state fair employment law. If you don't see your state here, it means that it's the same as the federal and it requires 15 employees. If you're interested in more details about your state law, check out our chart of state laws on our website. For people who need to take time off from work, they may want to access or see if they're eligible for leave under the Family and Medical Leave Act. The Family and Medical Leave Act is a federal law for employees to deal with their own serious medical condition or to take leave to care for a seriously ill child, parent, or spouse. Now, there are some significant barriers to FMLA, like the eligibility requirements. They only apply to employers with 50 or more employees. And you have to have worked for the employer long enough, which means that you have to have worked for a total of 12 months. And in the last 12 months, worked at least 1,250 hours. But the major benefit to the FMLA is that it provides you with up to 12 weeks of leave per year. And that leave is both job protected and health insurance protected, which means that you can't be let go or forced to take COBRA because you're taking medical leave or you're taking leave to act as a caregiver. So many people don't understand. They think, oh, I'm out on disability or I'm out on sick time, and they don't realize that that's not actually job protected and you could be let go unless that leave is designated as FMLA leave. As I mentioned, FMLA only applies to employers with 50 or more employees. So what happens to those people that work for smaller employers? Again, we're going to look to the state leave laws. So state leave laws are really sort of all over the place. These are just some examples here. But if you want more details, you can look on our chart of state laws. So all of that is to say, and I know I went through some of that rather quickly, but that's because we have tons of resources on our website, and they will be included in the resource document that will be available on our website. For people who need to take leave, as I mentioned, the FMLA is unpaid. So what do? Most of us can't go 12 weeks without any sort of income. That's where disability insurance comes into play. Disability insurance is an insurance policy that you have that replaces a portion of your income when you can't work due to a disability. And there's a couple of places that you can get disability insurance. So you could get it directly from an insurance company. It could be provided to you as a benefit of employment. If you live in one of these 5 states or Puerto Rico, excuse me, you could have access to state disability insurance. But many times in the cancer community, when we are talking about long-term disability insurance, we're talking about the 2 federal programs. These are both programs run through the Social Security Administration, but they have some pretty important differences. Supplemental Security Income, or SSI, is for individuals who have low incomes and asset levels. And the benefits start right away. The amount that you get is based on what state you live in. And typically when someone's eligible for SSI, they're also eligible for Medicaid in their state. So that's Supplemental Security Income, SSI. Social Security Disability Insurance, or SSDI, is based on having worked and paid in to the Social Security Administration during that working time. What you receive from SSDI will be based on what you've earned during that work history. So Mark Zuckerberg is theoretically going to get more money on SSDI than I would. SSDI also comes with a 5-month waiting period. So someone has to wait 5 months from their dates of disability onset in order to start getting payments. But there are some opportunities to get back or retroactive pay. Once somebody is receiving SSDI for 24 months, they then become eligible for Medicare. SSI and SSDI are, again, pretty complicated and there's lots of nuances. And so if you have more questions, I highly recommend that you take a look at our animated video on taking time off and how to pay for it, as well as our topics page on disability insurance. When I started the webinar, I mentioned that much of cancer-related legal issues is like trying to put a jigsaw puzzle together. And I've talked to you about some of the different puzzle pieces, but here's an example of how they actually come together. Meet Mark. Mark has 3 weeks of vacation, 3 weeks of sick time. His employer is covered by the FMLA and offers a short-term disability insurance policy for up to 12 months. Mark thinks he needs to be out of work for 15 weeks. So first, he can take 3 weeks of his sick time and 3 weeks of his vacation time to make sure those first 6 weeks he's getting paid for something. Then his short-term disability insurance policy could kick in for the remaining weeks that he needs for up to 12 months. But here's the thing. None of these things in blue actually protect Mark's job, which means at any point during this sick time or vacation time, or even while he's receiving short-term disability, he could be let go. Except we know that his employer is covered by the FMLA, which means that those first 12 weeks of leave are designated as FMLA leave, and it provides job protection and health insurance protection. But wait a minute, that's only 12 weeks. Where is he going to get job protection for the last 3 weeks? Well, he could potentially ask his employer for a reasonable accommodation through the ADA for an additional 3 weeks of job protected leave. So you'll see that certainly all of these different pieces could be used by themselves. But in order to get the most amount of protection, both with respect to one's job and health insurance access, but also with respect to access to funds, it's when somebody uses all of these benefits and policies and laws together that they get the maximum amount of protection. So if you would like to see any of that example again, that is what is included in our quick guide to the timing of Social Security, disability insurance, and Medicare benefits that can be found on our disability insurance topics page. So what's legal about cancer? Pretty much everything. And we really just scratched the surface in our 90 minutes together. So I certainly invite you to join us for future webinars. I hope you will consider joining us in October for our virtual conference, our all-day conference on a Saturday. And you'll check out our resources. And certainly if you have additional questions after looking at our resources, feel free to fill out that intake form that Madison mentioned on our website to access our navigation program.